Welcome to Global Health Science Statistics. So today in this session, I'm talking about the qualitative and the quantitative test. Just to give you some small background, once this prostate gland produces this PSA, some amounts, actually minimal amounts, have got the ability to escape into the bloodstream. Now, when we are carrying out the test, we are actually trying to rule out elevated levels, majorly when you are dealing with qualitative tests, to detect elevated levels above the cutoff limits. Now, just to bring you a little background so that you get this qualitative test runs like any other immunoassay test. So allow me give you the requirements for this test. 1, you need the patient sample. 2, you need the capillary tube. 3, you need the buffer. Then you need the cassette. Then you are going to obtain this sample, put onto the pouch on the cassette, the sample pouch on the cassette, add the buffer solution, and put it on a lateral surface, on a flat surface, and allow it to run laterally for a period of around 5 to 10 minutes. After that period, depending on the manufacturer's advice, some can be like 10 to 20, but I'm just using 5 to 10 as an example. Then you're going to interpret your results. Your results are either going to be, you're expecting around 3 types of results. You expect a positive result, you expect a negative result, and an invalid result. How do you understand that this is a positive, this is a negative, and this is an invalid result? This is very simple. For the case of a positive result, you're going to find both the control line and the test line reacting to be positive. For the case of a negative test, you're only going to find the control line reactive. For the case of the invalid test, you will only find the test line present without the control line. Such are indications of the invalid test. And what do you do when you find the invalid test? It is advisable that once your test becomes invalid, you're majorly advised to start the test afresh. In other words, pick up a new cassette and rerun the test so that you can actually obtain the best results possible. That is for the case of the qualitative PSA test. Now, I want to dive down to bring to you the quantitative test in details. So the quantitative test is actually done in several occasions when the qualitative test was a positive. So we do it in order to quantify the concentration of PSA in the blood. Now, so that it will help to guide treatment and the clinical department on what to do further after this has been ascertained. So majorly, the requirement that you require here is you need the ready top, and also you need the gold top to over the SST tube. So these two tubes, the ready top and the gold top, help you to obtain serum. This gold top contains a gel in it, which helps in the separation of the blood cells and the serum. The ready top is plain, has nothing in it. But at the moment the blood is put naturally, the blood will clot and serum will be produced. So after you have ascertained and you have got your things secure, including the micro pipette, then of course the sample tubes and your chemistry analyzer all set in place. So you're going to get your sample, allow it to stand for a period of around 30 to 60 minutes, that's around 1 hour, to allow this blood to clot and produce for you serum. After serum has been produced, you are still going to centrifuge at around 1000 to 1500 for around 10 minutes, revolutions per minute, in order for you to obtain this. Or you may choose to use 3000 RPM for a period of around 5 minutes in order for you to obtain this serum. After you have obtained this serum in particular, now you are going to use, with the help of a micro pipette, obtain possibly around 0.5 mils and transfer to the sample tubes. After you have transferred to the sample tubes, then you continue to, of course, ascertain the condition of your reagents in your machine. You ascertain the condition of the reagents in your machine, whether they are in good quantification or they are in bad storage conditions. All those are things you're going to check: the storage condition and the quantity in this chemistry analyzer. After all those things have been put into place, you're going to make sure that, remember, This process must have started at this level when you finish to do calibration of your machine and your machine is up to date to run procedures. So you are now going to continue to enter the patient's details on the machine and of course run the sample. This machine runs automatically these samples, but this is the procedural steps that take in place inside the machine. One, these machines are majorly dependent on ELISA or on ELISA test principles. Majorly, in several cases, they use what they call sandwich ELISA. So I hope you are well versed with the sandwich ELISA. Or maybe let me give a rough run through concerning this sandwich ELISA. Sandwich ELISA now takes place after you've stamped on your machine. Your machine will of course pick this serum sample from these sample tubes and transfer it using its needle inside this microtiter wells. Once it reaches into the microtiter wells, these microtiter wells are already pre-noculated with a capture antibody. So the capture antibody inside this microtiter well will of course react with this antigen. So there will be antigen-antibody complex reactions inside this machine. So after the antibody-antigen complex reactions have taken place, they will add the secondary labeled anti-PSA antibody. Once the secondary labeled anti-PSA antibody, which can be immunofluorescent labeled or it can be enzyme-linked labeled. So this one will come on top, just like you see here in summary. Everything is actually here running in summary. So you see that in the first step, this microtiter well already contains a pre-noculated primary antibody, which is not labeled. And then you bring in the patient serum containing the second containing the antigen. So that antigen will react with the primary unlabeled antibody. After that sequence has happened, on the third procedure steps, now you're seeing the secondary labeled anti-PSA being brought into this. After this secondary labeled anti-PSA, which can be immunofluorescent or enzyme linked, will come and bind to this. Then, of course, the washing process will come into play, where they will wash the unbound, these unbound materials of the reaction, allowing only the bound ones to stay inside. So once there is only the bound ones that have stayed inside, the light signals will be triggered. So the light signals will be triggered to produce light. And once the light signals are triggered to produce light, in several occasions, now we shall see this machine being able to measure the absorbance of the test. So the absorbance of the test which is measured is directly proportional to the concentration of the analyte which is being measured, which in particular here is the PSA. So then the machine, of course, has its own automatic calibration curve that is going to compare with the standards that are already pre-noculated inside. So it is going to measure and calculate, then of course bring out the results. When the results are brought out, this is what you should know, that you expect to find results based on the age bracket. For example, men of around 40 to 49 are expected to have a PSA of less than 2.5 nanograms per mil. Then those ones from around 50 to 59 years are expected to have from around 3.5 below as normal nanograms per mil. Then those ones from around 60 to 69 are expected to have around below 4.5 nanograms per mil. Then those ones from around 60 to 79, they are expected to have around below 6.5 nanograms per mil. That is an expectation. So depends on how your machine is set, but I'm just giving you what is actually expected of the standards in this case. Then you dive down to talk about what is the result interpretation. In several occasions, several chemistry analyzers actually consider that below 4 nanograms per mil is normal for every man at any age bracket. So in so doing, that means if somebody has got around 4 to 10 nanograms per mil, that is a little elevation, because 6.5 I told you was the last. So when someone ranges from 4 to 10, that is little elevation, which can be maybe due to recent ejaculation, overcycling, or any other infection or trauma which has actually happened to the prostate gland. So there is suspicion of infection to the prostate gland. Then if someone, so other tests can actually be recommended for that one's case. We can go ahead and do other tests, or we leave the patient to stay a little home for like 1 month and come back and repeat the test. That can be another recommendation that can be given to that patient. Then we go ahead and talk about this other next one, which can be ranging from 10 to 20. Someone giving you 10 to 20 nanograms per mil raises suspicion for maybe BPH, which is benign prostate hyperplasia, or it can be cancerous. So we start suspecting certain conditions of that type. So remember, PSA is not diagnostic. It's not singly diagnostic of prostate cancer or any other infection. So we shall recommend other tests to still be done on this elevated level of around 10 to 20. So what if someone has got greater than 100 nanograms per mil? That one actually provides a suspicion rate of the metastatized cancer. In other words, the cancer that has graduated extra beyond the prostate gland alone. So in so doing, you have to understand that someone with greater than 100 nanograms per mil is suspected to be having a metastatized cancer. That means the cancer that has metastasized means it has moved from its localized area of the prostate to advanced other tissues within the prostate. So what can now be done if such results have been done? So the confirmatory test that can be recommended for this patient with greater levels of high PSA elevation in blood is majorly histopathological test, which is majorly biopsy, of course, you obtain the tissue, then you go and run it in the histopathological lab until you ascertain, where a pathologist will perform microscopic examination and confirm and use the glass score method in order to understand how aggressive this cancer could be, if at all it is a cancer. So, of course, in order to ascertain how aggressive this cancer could be. Not only that, so there are so many things that now will come into play after that has been diagnosed. Of course, this patient will be recommended for maybe chemotherapy or other things that can come into play. So before I put this into conclusion, somebody previously, over my previous video, asked me to dive down and explain the relationship between these causes of elevated levels of PSA and actually why they cause the PSA to be elevated. For example, one of the causes of elevated PSA is recent ejaculation. How does recent ejaculation lead to elevated PSA? Let me break it down for you. We are going deeper now. So the elevated PSA in relation to ejaculation is in coordination. Once a man is ejaculating semen or sperms, you see that sperm and semen come at a force. So the constrictive force of this prostate gland, remember, it is one that produces that force, allows a creation of a few powers within the prostate gland, allowing escape of small amount of this PSA. That is in relation to ejaculation. Then how does benign prostate hyperplasia lead to elevated PSA? BPH leads to elevated PSA because hyperplasia simply means increase in the number of cells. This is non-cancerous, but the number of cells has increased, maybe due to increased workload or something else which is related to the increased levels of the cells. Once there is increase in the level of cells that have been producing a certain amount of protein, there will also be increase in the leakage quantity that will escape. Remember, I told you that this prostate gland produces this prostate specific antigen in a certain amount, depending on the number of cells available, and the minimal amount will escape to the bloodstream. Now, if a minimal amount escapes to the bloodstream, just like back to primary, they tell you if 50 people can eat 3 plates of posho, what if these people are 100? That means they will reduce the time. That also equates to this. If 50 cells can produce 10 meals of this PSA antigen, what if now you bring 1,000 cells? That means they will produce more. Also, the leakage quantity will increase. That's how BPH leads into elevated levels of PSA. What about cancer? How does cancer lead to elevated levels of PSA? Let me break it down. First of all, cancer is is unprogrammed cell division process, which leads to increased levels of cancerous cells. Now, if there is always increased levels of cancerous cells, just like BPH, of course, there will be overproduction of this PSA, also leading to increased leakage. That is point number one. Point number two, once there is cancer leads to what they call angiogenesis. Angiogenesis is connection of development of blood vessels to supply majorly and particularly these cancer cells. These cancer cells have high metabolic rate, and because of demand for nutrients, they will always lead into angiogenesis, which is connection of various blood vessels, also called vascularization. So in so doing, they will actually lead into connection of different blood vessels, leading into escape of more of the content produced. First of all, the number of cells is more, and the number of blood vessels connection is also more. That can also lead into increased levels of this prostate-specific antigen. Not only that, the moment a cell becomes cancerous, it will lead to destruction of the cell membrane. Remember, the cell membrane keeps the contents of the cell intact. And once there's damage of the cell membrane, automatically there will be leakage of the contents that have been produced by this gland into the bloodstream. That is for the case of that. Now, how is a physical examination or recent examination also associated to elevated levels of PSA? Now, there are different levels of examination here. You can talk about the DRE, which is digital rectal examination, which is a procedure that doctors do manually through the rectum to ascertain the level and the size of this PSA. So such procedures will, of course, lead to compression or pressing of this prostate gland. Once there is pressure subjected to the prostate gland, there will be minimal escape of this PSA into the bloodstream. That is point number one. Then when we talk about biopsies or obtaining of these tissues is a process by which living tissues are obtained for histopathological studies. So in so doing, they always use what they call a biopsy needle. So the biopsy needle is going to be pricked to this position, of course, with the help of an MRI, which is magnetic resonance imaging, or a CT scan to guide the movement of the needle. But at the same time, as this needle is being pricked in order to obtain this biopsy, there will be destruction of a few blood vessels, which will, of course, lead to a connection of the content, which is a PSA, to the bloodstream, leading also into elevated levels of PSA. So that's the relationship, deeper relationship between these causes and elevated PSA. So thank you. If you found this video really of great importance to you, I would urge you to subscribe, like, and share this video, because this is something which is very important and vital for our lives. Thank you for learning with us. I always remain your Global Health partner, Andrew, willing to bring to you better updates. Thank you so much.